Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. We're beginning with today's lecture, and it was about current topics in prosthodontics, especially in rehabilitation and occlusion adjustments. Okay, so today's presentation was a beautiful presentation presented by Dr. Majd, and I have multiple comments on it. But while you were advancing in the presentation, I found many of the answers that for the questions I have raised. But actually, this is a part of our exercise where you present a presentation, and then me as an advisor, ask for some adjustments in it to include a little bit more information as one step ahead for you to gain more knowledge. I like the presentation. It was well presented. Some of the images were a bit elongated, but that's fine. But the idea is that we present a presentation with PowerPoint. The student presents it fully. Then I do a commentary on it. Okay, so this is the video of the commentary. And then we ask for some adjustments, and we have some questions. First of all, I ask you as students, please include your questions first. So and then I'll begin. So other students, do you have any questions to Dr. Majd based on his presentation? Dr. Sama, Afaf, Abdullah.
It was clear.
It's okay, Doctor. No.
Okay, thank you. Okay, so you don't have any questions. Then I'll begin. This exercise we're going to do, your presentation had included multiple subjects. I like the subjects where you have listed these subjects in line. I'm going to try to change. Okay, see how this will move. Okay, so these are the presentation topics. They were well diverse, as we liked. We need a diverse group of topics because we need to introduce multiple issues in one place, in one presentation. So the diversity of your presentation is beautiful. You talked about digital occlusal analysis, and you talked first of all about bite assessments. So you're talking about intraoral records, and these are bite records. And then when you were talking here about the comprehensive bite assessments, you went into digital jaw tracking systems. Usually these are for extraoral. Try to divide them as intraoral occlusal analysis and extraoral occlusal analysis. It will make it easier for the reader. I know you've taken this from this paper, but you can divide them in a mind map just before this slide. You can add that some of the systems analyze the intraoral landmarks or features or analysis of the movements and extraoral. So those that are intraoral only are better to be placed alone. Okay.
Yes, Doctor.
Into intraoral scanners, it was beautiful. I liked where you talked about articulation, but articulation itself, conventional articulation, what did you mean by that? What did you mean the word articulation? Because you have used it multiple times in multiple slides. I want to make sure articulation has many meanings. So which meaning did you use, for example, here?
Conventional articulation means when we take impressions upper lower, then bite registration, conventional bite registration material, then mount them on the articulator, just like this.
So it was the orientation of the upper and lower cast together.
Yes.
Regardless of the technique. Okay, this is articulation and what we need. Okay, that articulation technique, how these were for edentulous. Were this study for edentulous or dentate patient?
No. For dentate patient, regardless the number of missing teeth. Yeah.
Yeah, okay, so there were some edentulous areas. In your presentation, I haven't seen any articulation for edentulous patients. So if you can find for the same systems that you have presented, stuff related to denture articulation, I would, edentulous ridges, how are they articulated for denture construction purposes? Okay, using the same systems, you might find, you might not find, I'm not sure, But please
Yeah.
try to go from that perspective, going back and adding anything regarding edentulous patients, add them here. If it was
Yes,
an
okay.
edentulous upper and lower or single edentulous arch, okay?
Yes,
It will
okay.
suffice, because this is one of the aspects that somebody might be looking for these articulation systems for their work is for complete denture patients, okay? The effect of number of teeth on accuracy and the scanners, we were talking about the scanners, you talked about the periodontal ligament plasticity. I love this work here. You talked about how they solved it in one way, and you talked about the accuracy of the scanners. Before, this is extraoral, digital jaw tracking system. Let's keep us with the intraoral. Now, I tried to pick up from your presentation, how do they record, for example, the maximum protrusive, the maximum retrusive, which is the RCP, the maximum opening, the lateral excursive movements? Can these systems record anything like immediate shifts? Can they record for group functions or anterior canine function excursive movements? Can they go through all of these records that we usually do, or these types of information? Can they detect them?
Doctora, this is not related to this study. This study is about
I'm not talking about this study.
yeah,
No,
but
not this study.
I'm
talking in
coming to
general.
this. Yeah, in general, they can simply do protrusive records by the same material and scanning for this protrusive record. It's
Okay.
like it's like the customization of the incisal table. We use the Duralay, same technique.
Okay. Excellent.
Protrusive record and
I
excursive record.
understand it, but the slides don't include them. Okay. So what the idea is here is, how are you going to do using intraoral scanners or extraoral scanners or whatever system? How
Dynamic
do you work
record.
with the superimposition? The way they do it is actually doing something manually, but by the superimposition of images, they omit the record block or the leaf that they used. Okay.
Yeah.
So this is how they do it. So you need to put a couple of slides on how to produce the not the centric occlusion, but all other records inside oral. How can that be done in steps? For example, if I want a protrusive record, I will create, for example, an acrylic leaf. I could put the patient manually inside the patient's mouth clinically, put them into that position using that leaf, and then I'm going to scan, and by superimposition, the block will be deleted from the image, but the other relation. Same thing for the lateral excursion, same thing for the RCP. Okay?
Yes, okay.
So try to put those in sequence if somebody wants to use these intraoral scanners for these eccentric locations of the jaw. Okay? Okay. You've talked about one system where they looked for, let's go to the extraoral for the TMJ. But let me just 1 second. Okay, when you talked about the mesh interpenetration, okay,
yeah,
where the periodontal ligaments had produced some movements, it's part of the fremitus of each tooth. So when you actually scan the teeth in full occlusion and maximum force applied for the patient, they will not be the same as the first initial occlusion point. Okay, they're all in maximum intercuspation, by the way. We're talking all of these contacts are in maximum intercuspation, but maximum intercuspation as an initial contact, then a maximum intercuspation with force applied to the occlusal table. These are different because of the small fremitus and some of the path of interferences that the patient might have. So you have explained this very beautifully. I like the work and methods to eliminate the effect of this interpenetration. I love this work. Okay. Yeah. So we talked about articulation. By the way, can any system can any of these systems record the full envelope of movement?
I didn't search it. No, I didn't search it. I don't know.
What I wanted to get from that is maximum intercuspation. It might be taken intraorally or extraorally. For the intraoral, you haven't seen any.
Okay.
Okay, just make sure if there are any intraoral scanners able to detect that, because in the extraoral scanners you talked about it when you talked about the TMJ and the position of the TMJ and the combination of these systems with other diagnostic systems as the CBCT.
So you need any system that can record the max intercuspation
from intraoral scanners.
from intraoral scanners.
Can they do the maximum? For example, I want to the maximum opening point. Can I measure that using intraoral scanners only?
Okay.
Okay, so the idea is using intraoral scanners for the maximum points of articulation, especially the envelope movement. Okay.
Yes. Okay.
Okay. And, going to the extraoral now. Okay, just make sure that I finished. Are there any mobile applications for intraoral scanners?
I don't know.
I sent you one.
Yes.
Okay, the idea is that there are some new, whenever we talked about full articulators, do you remember that? Full adjustable articulators and digital face bows. You always looked at those devices as the most elite and the most expensive. Now with the CAD CAM, it allowed us to do more simple scans and much cheaper. Now, what we had last time I sent you the image of a video where somebody had something attached
You
to
mean the video I sent in the WhatsApp?
Yes, I sent it on the WhatsApp. If you can get that name of the product,
Okay.
if you simply can take an image, go to Google Photos and use Lens to find similar images. You might go and find that video or the source of the video on the net. It's the idea they have applied something extra to the mobile. They attach it to a mobile, and it also does some retraction for the lips, and you begin measuring and taking images using the mobile phone. So this is a beautiful thing for us to add as intraoral scanners. By the way, this might be much easier if this application could be
more efficient.
Yeah, it's very efficient. It's you can do it easily in the clinic. And it goes, if you can tie it with the CAD, with the CAD CAM software, and then the CAD milling. So that will be excellent. It's much cheaper for intraoral scanners. So add that. I would like you to add that. Or anything else you find for intraoral imaging using mobile applications.
Yeah. Okay.
Okay. You can find them in ortho sometimes. The good thing with ortho applications for these scanning or scanners, they will give you the interocclusal relationships as well. So if you can find on those, please, that will be very beautiful. Okay.
Okay.
Okay. So add that. What else? Okay. When we talked about intraoral scanners, and then extraoral, I'll do this comment later on. Let me just, it applies to both intraoral and extraoral. I'll leave this. Okay. What are the clinical applications of these intraoral scanners? You have talked about them, but when we talked about the extraoral, if you can elaborate more. One of the studies that you presented was talking about the indications. I'll also leave this for the extraoral. Okay. Once more, can, for example, the intraoral scanners detect the resting position, the natural resting position? Can it detect the swallowing initial contact position? Yani it could do, can it replace the Gothic arch tracing and so on? So these are some of the things I would like to answer for intraoral. Okay, let's go to extraoral. So jaw tracking systems, you talked about them. You talked about the photometric and the magnetic systems, ultrasound systems as well. I love this. But I would love to see if they can be exported to CAD CAM. This was beautiful. This one is beautiful. But what are the clinical indications for using these devices? I could not pick up what are the clinical applications. So try to add here, what are the clinical applications for these systems, okay?
Okay.
The ultrasonic scanner tracking systems was beautiful. Could they take the images? But once more, the same question, can these extraoral tracking systems detect the envelope of movement? Okay, same question applies here. Okay. Okay. This is the 4D motion system as well. How did they do it? The tracking accuracy. Once more, the envelope of movement. Does it apply here? Can we track it? Especially when we're talking about the envelope of movement allows us to study really the limitations of TMG in cases of TMD. For example, if there's a limited lateral shift or limited protrusive shift or limited opening, all of these are part of the diagnosis of TMD. So this is why I'm insisting on having these maximum points on the envelope of moment. But also, do they provide dynamic records where you can see an immediate shift? It's not immediate shift. Can they detect, for example, any shift in the maximum opening procedure? This should be dynamic because you need to have an opening point, then a midpoint, and then the final point of opening, especially when there's a restriction or any shift in the mandible while opening. Okay, the shift could be in the middle of the opening path, or it could be on the end of the opening path. So do they provide these extraoral tracking systems? Do they provide dynamic records detecting any shifts in the TMJ? Okay, and then once more systems, clinical indications, please. Okay, the T-scan was very beautiful. I loved how does it work. Now, see this, we're here for the T-scanner. What did you do? You gave us the hardware and what is the software, okay?
Yeah.
Okay, I want the same thing for these. Okay, sorry, if I go back, for these systems, what is the hardware? How do I buy it? What do I get in the package for them? Okay?
Okay.
Okay, so what are
If I found them, sometimes you can't find everything, but I try to search them in the catalog product.
Yes, this is a very, because somebody might need something. For example, from this picture, I could detect that it will have something like a Facebook and have something for intraoral piece. But other systems, I don't know. The something here, for example, here, do you have any extraoral? Are these the only parts? So the hardware is so and so, and the software is a software inside the computer. So it's just easier to understand them, especially. Okay.
I was here aiming to just to differentiate between the mechanism, how they work. You have photometry, magnetometry, you have infrared camera. I just wanted to.
This is excellent, but this extra information is very beneficial for those interested in these systems. Okay.
Okay.
Because, by the way, occlusal analysis and the one of the cases you presented, actually we don't have this here in Jordan. A center specialized in adjusting TMD. Okay. With the only thing they provide you is with night guards. They don't have devices, diagnostic devices. We have an oral maxillofacial pain, center in the hospital we have in our country and our city, but they don't have these advanced tools. Okay, so somebody might be interested in opening such a center where they resolve TMD using these advanced systems. It was very beautiful, especially when they use the T-scan with other types to adjust the occlusion. Okay, I loved where you talked about the limitation of this system. It might be the most famous one. So you talked a little bit about the limitation. I love this slide as well. Benefits and the limitations here. Yeah, very beautiful. Okay. Electromyography, this is an excellent tool as well. I know it's present, it is present, and it's present, but the dental application of it is beautiful. I love the way that you've done it. This image shows you the hardware, okay, and how you can use them. If you have anything new about them, especially electromyography using mobile applications where you can have sensors attached to your mobile, if there are. Okay, so you have beautifully presented this. Also, you talked about the customized prosthodontic solutions for patients with special needs. I love this case. It was very beautiful. Okay, here they used intraoral scanners. Yeah, صح?
Yeah.
Yeah, intraoral scanning. Okay. So nothing extra, just giving you the digital flow of the work. This was also beautiful. But in this case, was it compensated or not?
No. According to the finding they listed, there was no يعني كان في عنا reduced bite, but there was no compensation. They
Okay.
didn't list
How did
any
I know?
compensation.
By the resting position.
Yeah.
The difference between resting position and swallowing position.
Yeah. Mhm.
If both of them, okay, the swallowing should have, this is one of the physiological checks for the vertical dimension. Try it now, swallow, please. What do you get?
Again, doctor.
You swallow, try it on yourself.
Okay.
When you swallow, you get the very initial contact between teeth.
Mhm.
Okay, in patients that don't have compensated wear, meaning that the bone did not follow and the teeth did not over erupt, dragging the bone upwards, what would they get? Even with the swallowing, there will be a freeway space.
Yeah.
Okay, so it's the difference between resting position and swallowing position. This is why I asked in the beginning for intraoral scanners, can they detect the resting position and the swallowing, initial contact swallowing position or not? Because this
Yeah.
will solve a lot. Sometimes you will not be aiming to do a full rehabilitation, but a patient that has one tooth or two teeth with problems, you might solve it by just checking, and you will find that they have a reduced bite less than what is seen here. Definitely, this case, the patient came because of the complaints. He had sensitivities and endo. But
Yeah.
suppose you're a patient that doesn't have any complaint, but there are some loss of some cusp tips, and you want to do some rehabilitation or you want to do some procedure. So part of the procedure would go back to adjusting the vertical dimension of teeth. Okay,
Of
so
course. Yes.
so this is why I'm asking if there was a system, a digital system that could detect the resting position, the natural or mandibular resting position, and the mandibular position once following, it will give you an alert that this patient has a reduced vertical dimension, and you may or may not include it in your restoration procedures. Okay.
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 Yes.
So this would be a great application for these digital systems. Okay. You talked about the treatment planning. I love this where you correlated the procedure with the CBCT, and I love where you could see the TMJ. Okay. And you also could do that with the leaf or gauge. So
Yeah.
you included that as well. Thank you. And this is where I talked about if we could get these positions without the need for the jig, actually. Okay?
Yeah.
The retruded contact position, the maximum protrusive, and the lateral as well. So this will be much more beautiful if we could get it digitally, not on with the need of a leaf. Okay?
Of course. Yes.
Okay, this is I love this where they done it. The new position of teeth, and it was a beautifully presented case, really, actually. And
Yeah.
how did the patient get into the final result? So it is a full rehabilitation case. And this is what I said about having a center that they have all of these devices in one place. Okay?
Of course. Yes.
Yes, this is very beautiful. Thank you very much. Thank you for your references. One adjustment that will be going on our homework. Okay, remember that your homeworks were 2 papers of guidelines and 2 papers of related to systematic reviews. Now, after your med, you've presented very well. So I am now trusting and happy that you satisfied the first aim for this course, where you can read, pick up, and even differentiate between outcomes of different systematic reviews. Now, our homework will change a bit, where you're going to pick up a larger number of systematic reviews. The guidelines are the same. We need 2 papers for each student, but then the systematic reviews, we're going to increase them up to 4 for each student. Two on the same subject. If you find that you don't, the 4, let's say the 4 are on the same subject, but many times you will not find enough systematic reviews because now we're going to in the more specialized specialty subjects. So if you don't find the same amount of systematic reviews, you can pick up systematic reviews that you have missed from the previous subjects, okay? So we're going to reorganize the systematic reviews in the same files that you sent me. Do you remember the files you sent me? With systematic reviews per subject, yes? You also can use, to make it easier for you also, you can use systematic reviews in your presentations. I know that many presented systematic reviews in the presentation. When you went to go to do a homework, you looked for other systematic reviews. You can include the systematic reviews that you have used in your reference list for those that had done some presentations with systematic reviews, okay? So it's just to make it easier. Now the total is 6 papers per student, and it could be 4 for the same subject. The other 2 on the same subject. If you don't find them, you can refill other systematic reviews in the folders that you sent me. And please make sure you present all of these online first and then put them into the files, okay? So this is our adjustment for our homeworks. Thank you very much. It was very interesting. And I always ask my students, do you allow me to present your work online for a PowerPoint? For YouTube?
This presentation?
Yes, if you like. If you can.
Of course.
Okay, thank you. Dr. Abdullah also gave me the permission. It will be very, very beneficial for students to see your presentations. Your presentations are excellently wide-ranged, multi-topics, covering a huge part of what we need for this course. Thank you very much, Dr. Majd, and see you in the next presentation.
Thank you, Dr. Abu-Naba'a.